and then she presented with her PPROM. So definitely in her, if she were to have an upcoming pregnancy, I would say for sure serial cervical length screenings. And then it's a little bit difficult, I would say, to decide if she does or doesn't meet criteria for history indicated cerclage. I think that's something that maybe, it would be discussed at an MFM consult because the definitions are pretty specific. I actually reached out to some of the fellows to ask their opinion, and I think it was difficult to come to a consensus. So I feel like it would be something that, we would decide as a group.
I see that Dr. Sagaram has her hand up.
Nina, great presentation. One point that I wanted to make is, we make a big deal about no C-section before a certain gestational age, trying to avoid those types of interventions. But I think it's really important to know that one of the indications for a C-section, even if it is at that 22 to 23 week mark, is obstructed labor. If a patient is laboring and it's not going anywhere, you're going to have to do a C-section to get that baby out, because we've run into problems before where patient can become infected, can become septic, and turn into hysterectomy. It can be a very big deal. So, yes, if we can avoid, and that's what the patient wants, that's great. But I think we have to keep in mind that obstructed labor is and should be a reason for a C-section at that time.
Adding to Dr. Sagaram's point, especially in a footling breech presentation, we have to be careful because these patients may deliver a majority of the baby through incompletely dilated cervix and have cord prolapse, and then can have head entrapment. So extremely important to keep that in mind, and that you may have to do C-section in these patients for sort of maternal indications. Another point, Nina, a question for you. So we know about the NICHD data. I think I've asked this question previously to NICU colleagues. Do we know of our data? What is our data of survival at 22 weeks, 23 weeks, 24 weeks?
Dr. Sharma, that's actually a really good question. I didn't ask the NICU fellow for RWJ specific data. One interesting thing that she told me, though, is that nationwide, so obviously different hospitals have different policies on how early they resuscitate neonates after birth. And there is somewhat of a trend of, for example, states that have more restrictive abortion legislation are ones that usually resuscitate early gestational ages. One random thing she told me was that in the state of Iowa, for some reason, they have the highest and best outcomes for like peri-viable neonate resuscitation. But our NICU department in general, there's no consensus as to why Iowa does so well, but that is something nationwide, at least, that she found. But to answer your specific question, I don't know. I'm sorry.
I see that Dr. Konopinski has her hand up.
Hi, good presentation. I just wanted to comment that throughout your residency, all of you should go in with the NICU and listen to the way they counsel our patients. And you'll be shocked to find that they counsel very differently than OBs and MFMs do. And that's probably something we should rectify and start doing co-counseling with our patients.
All right. Well, thank you very much, Nina. Excellent job. All right. So we'll switch gears now and get ready for grand rounds. In just a minute, I'm going to ask Dr. Sagaram to introduce our grand round speaker. But in the meantime, just a few announcements about attendance. We'll be taking attendance at 8:10 using the participants list of the WebEx. If your name is not listed clearly, or if you're calling in, or if there are two people at the same computer, you can email your attendance to me or Michelle or Beth. And the CME code will be distributed via the email system. And with that, Dr. Sagaram, are you ready to introduce our speaker?
All right. I am so pleased to have the opportunity to present our speaker, Dr. Kelly Wright. Dr. Wright is the director of the Division of Minimally Invasive Gynecologic Surgery and an associate professor of obstetrics and gynecology at Cedars-Sinai Medical Center in Los Angeles. She received a BS in biomedical engineering and an MD from Texas A&M University. She did her residency at Brigham and Women's in Massachusetts General Hospital in obstetrics and gynecology, and her fellowship in minimally invasive gynecologic surgery at Newton Wellesley Hospital in Massachusetts. Her CV is prolific, and I could not do it justice in this introduction alone, but it is clear from her many publications, lectures, and role as a mentor that she has carved a place as a leader in her field and as a teacher who is shaping a generation of young physicians. She currently serves Cedars-Sinai in several capacities, including implementing enhanced recovery after surgery, increasing telehealth utilization, and decreasing hospital waste production. It is on this last topic that Dr. Wright will share her expertise with us today. I am looking forward to hearing her talk titled Climate Change Begins at 7:15, Our Unsustainable Future in Healthcare.
Great, thank you so much for having me. Will someone just confirm you can hear me and see my slides okay?
Yes, we do.
Thank you so much. All right, well, again, thanks for having me, and hello from the West Coast, where it's still a little bit early, but I'm still happy to be up and presenting this to you because I'm really pleased with the opportunity to share the information anytime I get the opportunity. Some of what you're going to hear today won't be fun to hear. Some of it might feel a little bit hopeless, but as it always can when we talk about the climate. But what I hope to leave you with is moving beyond hope to actually the work that we can do to right the ship in our own industry. So these are my disclosures. Most importantly, I'm not a climate scientist. I don't think any of us are, but I am a contributor to and an observer of the waste we create in the OR every day. And we've really normalized something that's not normal. When you bring somebody into the operating room who isn't usually there, they are usually overwhelmed by the amount of things and the amount of waste that's going out every day. So let's start to think about relative contributions of different industries to pollution and waste. And you can take Los Angeles, for example. So we're a big place, 4 million people in the city, 10 million people in the region. And if you had to think about who creates the most waste or who's the biggest polluter in the city, you know, there's a couple things you might think of. One, my hospital, it's a 900-bed hospital. We do 55,000 procedures a year and 7,000 deliveries per year. It's quite a big place. We have the UCLA undergraduate campus with over 30,000 students. We have the Staples Center, something depressing now, like the cryptocurrency.com center, but it hosts multiple professional sports teams and millions of people every year. Or a place like SoFi, which hosted the Super Bowl and hosted Taylor Swift and Beyonce almost back to back and restarted the LA economy and can hold 100,000 people at a time. But if you ask who the biggest waste producer is, it's actually us. And when I first found this out, I was quite embarrassed, but come to find out most hospitals are the biggest waste emitters in their communities. And that includes large cities like Los Angeles, New York, Chicago. Hospitals are either number one or number two when it comes to the burden of waste we're creating. And then if you went even further and compared the carbon emissions of global healthcare versus global aviation, you might be surprised to learn that global healthcare produces more than double the amount of global aviation. While there's regulations on flying and more bans across the world on certain types of flights, we get relatively no scrutiny for this. Similarly, in California, you won't be able to buy a gas-powered automobile after 2035, or a new one anyway. But if you compared auto manufacturers to pharmaceutical companies, pharmaceuticals create more emissions every year. And because we have no scrutiny and no regulation, we're on track to double our emissions by 2050, as opposed to being along the dotted line, which would be in compliance with the Paris Climate Accord. And this is a very American-centric problem. Despite having only 4% of the world's population, we're contributing 27% of the global healthcare footprint. And if you add that up and compare it to other countries as a whole, that's more than the entire UK as a country. So countries have goals for their emissions. Certainly our own healthcare industry, which is supposed to support health, should have goals for our emissions as well. So that's what we're going to talk about today. We'll talk about where our huge impact comes from, discuss some of the data on the effects on patients, and that could be a whole talk in itself, but I'll just skim the surface on some things that I think are really important, and then prompt action for what we can do in our own operating room, our own hospitals, our systems, and our regions. So where do the big problems come from? How are we producing this carbon footprint? Well, we're the second biggest users of energy after food service, which uses a ton of refrigeration, we're the biggest users of water and we're the biggest producers of waste, generating 14,000 tons of waste per day. A big portion of that is single-use plastic waste, of course, and sadly, some of it is food waste because we do a bad job of proportioning out healthy food for our patients and our staff. We're the biggest user of pharmaceuticals worldwide and the biggest user of pharmaceutical packaging. And packaging is FDA regulated, but it's a $20 billion industry. And you can see 3 months of contraceptive packaging for somebody who might have to contracept for 40 years is certainly an unsustainable thing here. But the biggest area where our carbon emissions come from is something called the supply chain. And you might have never heard this word before COVID and wish you'd never hear it again because they're constantly talking about it. But what it refers to is essentially the entire life cycle of an item. And that's from the creation from its native elements, usually of petroleum-based single-use plastic, to the packaging, the shipping, the use and the disposal of the device at end of life, and the packaging and the shipping boxes, the entire footprint of that item as it goes through its life cycle. And it's always healthcare, and healthcare labor has always been the biggest cost. But it was thought that supply chain overtook labor either last year or this year. So these days we're actually spending more money on stuff rather than people. And this is where our carbon footprint is coming from. And the OR, despite having a relatively small square footage in the hospital and a place that's not used 24/7 like other patient care areas, we're responsible for a big portion of this, up to 60% of an organization's total supply costs, a third of the waste, and 2/3 of the regulated medical waste, or the red bags, or what's called biohazardous waste. We consume energy there more than anywhere else in the hospital. And then there's unique issues to surgery like volatile anesthetic gases and exhaled CO2. And for example, on the gases, desflurane is a potent gas that's used, and 1 hour of use is equivalent to driving 375 miles in a gas-powered automobile. So what we're doing in the US today surgically is a major propellant of climate change, and it's not sustainable. And how does this affect our patients? It was in 2009 when the Lancet first said that climate change is the biggest global health threat of the 21st century. And the impacts will be felt all around the world, not just in some distant future, but in our lifetimes and those of our children. And a lot of the early data really focused on the pediatric population, but that's been expanding more and more and more into OBGYN and now into other surgical fields as well. The WHO puts out a report every year on how there's gender discrepancies in climate crises. More women die than men, and that's across all socioeconomic areas and nations. And then we know there's the negative effects of heat, air pollution, which is usually reported in particulate matter, nitrous oxide, and then the effects of toxic substances and plastics as well, which again, I'll go over real quickly here. And also, climate disasters are healthcare disasters. Out of 100 hospitals who serve catchment areas of 8 million people or more, 45 of them have had to declare emergencies due to extreme weather events like fires, floods, freezes, power outages, water outages. And we've all probably become familiar with this systematic review that was published in 2020 from JAMA, looking at over 32 million births that showed that air pollution and heat exposure was associated with negative birth outcomes, including preterm birth, low birth weight. And this effect was seen across all geographic regions and unfortunately affected minority groups more than others. But I think even when you distill down further into more local populations and local pollution, it's very interesting. This was a study out of California looking at 5.9 million births. They geolocated the addresses to coal and oil power plants that subsequently closed, and then they measured the effect on birth outcomes for what happened when those power plants closed. And they found that there was a 27% reduction in preterm birth. This is important because this is what 17-OHP was supposed to do, but maybe wasn't reproducible in all populations and therefore isn't really around anymore. But our climate data is reproduced over and over and over as showing these big effects, as big as treating people medically. This was a study looking at 1 million births, looking at Black-white disparities in preterm birth, very preterm birth, and small for gestational age. And they found that neighborhood air pollution was a bigger predictor of all of these disparities, even more so than things like poverty rate, Medicaid enrollee, or whether you speak English as your first language. And even into early pregnancy, getting into the GYN world, this was a study in Nature Sustainability out of Shanghai, and they looked at 250,000 pregnancies that ended in missed AB at 14 weeks or less. And they geolocated these patients' home addresses and their work addresses, knowing that patients in the first trimester are often still working, to pollution monitors that are set up around the city, which they have. And of course, they found an increasing odds ratio of missed AB compared to the amount of particulate matter that people were exposed to. And just to give you a sense of what these higher amounts of particulate matter look like, so the Quebec fires that put smoke across the East Coast this summer, in 2 days would have reached, a patient would have reached the highest levels of exposure on this graph. So something that's really applicable to us and particularly fire season. And then in other fields, this has been shown as well. If you have a cardiac transplant, the more particulate matter you're exposed to, the more likely you are to die after your transplant. Even in something like bariatric surgery, you might think might not have an effect. But patients who were exposed to more air pollution, or what's called traffic-related air pollution, had less weight loss, less change in their A1C, and less change in their lipids, even up to 2 years after bariatric surgery compared to controls. These are real patient-reported outcomes that we measure as far as our success of what we're doing in surgery. And yet the environmental impacts and the pollution are having a major effect. And then if we get more into our toxic substances as well, we really want to focus that on plastics. Plastics are everywhere, of course, and microplastics are essentially the breakdown of that down into particles that are less than 5 millimeters in size. And microplastics have already been found in our food, drinking water, and human intestine for many years. But 2021 was the first study showing that microplastics were now found in the placenta, and that was in all placental portions, the maternal, the fetal, and the chorioamniotic membranes. And of course, this has implications for fetal development and cell signaling. Microplastics have now been found in fetal meconium as well. And they've also been found in our blood. This was a study of healthy volunteers from the Netherlands, just giving blood samples, looking for plastic polymers. And you can see most of them had plastic polymers in their blood. Even something like the yellow is polystyrene, that's styrofoam, or polyethylene, which is a soft plastic incorporated into lots of medical grade plastics. Many of our medical grade plastics have what are called endocrine disrupting chemicals in them. So as the biggest polluters and using lots of plastics, we're also putting out EDCs from our facilities. And things that are incorporated into our supplies are things like phthalates, which is called a plasticizer. It makes plastics soft. So everything that it feels soft, it also holds color and it holds fragrance. So it's used in beauty products as well. It's also incorporated in some medications to control delivery. So it basically holds on to things. ExxonMobil is the biggest producer of phthalates. And to be honest, when we decarbonize from fossil fuels for energy, they're just going to keep producing phthalates because we use them so much. Parabens are used for their antimicrobial properties, and they're put in ultrasound gels and can be absorbed through the skin. Same thing with BPA, BPS. They're used as liners and dialysis and ointment tubes, and those can be absorbed transdermally as well. And this observational study looked at exposure to EDC for patients who were admitted to an L&D and a NICU, and they found that 74% of admitted patients were exposed to one EDC, at least one EDC. And in the NICU, some of the toxicity amounts exceeded recommended limits based on the neonate's small size, and phthalates in neonatal males have been associated with neurodevelopment issues. So we should be petitioning to get these out of our supplies. Lastly, I want to submit to you that the waste we're creating is probably racist. We've all heard of redlining, and what you might not know is that was also used to reclassify historically Black and minority neighborhoods from residential areas to industrial zones so that toxic waste facilities could be placed in those locations. And to this day, 8 out of 10 waste facilities are still located in Black and minority neighborhoods. And so if we want to talk about social determinants of health, we need to know exactly where our waste is going and who it is affecting. And we really should be focusing on our waste and pollution mitigation if we really care about these factors. So now that I've told you all the bad news, let's talk about potential solutions, because the more I've done this, the more I've gone down these rabbit holes, what I've learned is that the data does exist to support change, and nearly everything we do in the operating room and the hospital is related to culture and incentives and not evidence based on patient safety. And you might have heard the sentiment, well, individual action doesn't matter. Why are we talking about this? Making climate change a personal responsibility distracts from the impact of industry. But as surgeons, we are the culture and we drive the industry. We are the industry. So as I go through some of this data, I want you to think about your most common procedures. What kind of waste is produced from that? How much exposure to EDCs occurs in your hospital, both for yourself and for your patients? And then think of all the things we do or the processes we have that don't make sense. And what is the evidence for those processes and how can we change it? We can distill down where our carbon footprint comes from even further, even on the operating room level. And this is a great paper done by our colleagues at McGee, led by Cassandra Thiel, who is a climate researcher at NYU, and it's called a life cycle assessment. And it's basically bringing in engineers for a procedure and evaluating everything that's going on, everything that's coming in and out of the operating room during a procedure. And it really gives powerful information. And I'll show you what their analysis looks like. And it looks really busy, but when I break it down for you, it can be really powerful. So every small bar is a different type of hysterectomy. We've got abdominal, vaginal, laparoscopic, and robotic. And then every larger section is an impact on climate change. There's things like greenhouse gas emissions, smog, acidification potential, carcinogenic potential, etc. Climate scientists will tell you that they don't know which factor is the most important component in climate change. They're all important. But when you put it together, you can see trends on the overall drivers of our emissions and climate change from our procedures that we're doing. And this graph has an overwhelming amount of green on it. And the green is all of our single-use supplies, our gowns, gloves, all of the single-use materials that we use in the operating room, as well as single-use instruments. You can see to a much smaller extent the purple, those are our anesthetic gases. The red is our HVAC systems, our electricity, our generators, everything in the operating room. And then to a much, much smaller extent, the blue is the sterilization and washing of everything that we're using in the operating room. So we really need to focus on the green. Again, all of this stuff that's coming from the supply chain is driving our emissions. And I'm going to show you how all of this stuff actually isn't making patients safer. The authors of the study proposed that we could reduce our carbon emissions from laparoscopic surgery by 80% simply by doing a few things, and that's minimizing open materials, stop using heat trapping anesthetic gases, which is fine in GYN surgery anyway, because ERAS protocols usually call for propofol-based anesthesia based on high risk of post-op nausea vomiting. Maximize instrument reuse and single-use device reprocessing, and then reducing off-hour energy use in the operating room. We've heard this our whole lives. This is reduce, reuse, recycle. And a lot of the focus has been on recycling, which is great, but it does take a lot of energy to break something down to its native elements and then build it back up again into something new. So what we really need to focus on is reducing, and we can reduce a lot of that green. I love this study out of City of Hope. This was done during COVID. City of Hope is a cancer hospital here in Southern California. They only treat cancer. So while they shut down for a very short amount of time, they continued operating for most of the pandemic, even when other hospitals were closed for surgeries. But their supply chain did dry up, and they looked at what happened when all of their things like single-use head coverings, single-use face masks, single-use foot coverings, when all of those things went away. And their surgical site infections went down, and it didn't go down by a little bit, it went down by almost half. That was despite an increase in the number of surgeries they were doing and an increase in the number of contaminated surgeries they were doing because patients were presenting later for care. Well, how could this happen when all this stuff goes away? Well, they did notice an increase in hand hygiene during this time. And it's probably the vigilance to do the simple things, which actually makes a difference when it comes to patient safety, as opposed to all of the things that we use, which I now call a safety facade, which don't have evidence for promoting patient safety. We saw this before. We saw this with the AORN bouffant thing. They made the recommendation, we have to wear bouffants, it's safer, and the Joint Commission took it a step further and said you have to put it below your ears. That'll really make patients safe. What happened was subsequent studies showed no, it wasn't any safer at all. And in fact, in some service lines, surgical site infections went up. So these things that are based on evidence and culture are not based on evidence, they're based on culture and theoretical protection are actually making patients less safe. It's the same thing with scrubs. Maybe you've been at an institution where you have to change your scrubs every time you come in and out of the operating room, or you can only use hospital laundered scrubs. But this has been looked at in a randomized controlled trial, actually of OBGYN residents. And they randomized them to have their scrubs laundered and get dressed at different locations. So either have your scrubs laundered at home and get dressed at home, all the way to have your scrubs laundered at the hospital and get dressed at the hospital. And they cultured them up at all different times of the day and looked at the patients that they followed. And of course, there were no difference in cultures. There was no difference in infections. It doesn't matter where you are laundering or where you're getting dressed. But again, this is an issue because over laundering uses a ton of water. For example, using one blanket uses 2.5 gallons of water. So even consider the things that are reusable and the impact that you can have if you're overusing that. And because I've been doing this a while, people now send me pictures of processes in their hospitals that don't make sense. And this is a friend of mine in a hospital who is now wrapping their scrubs in plastic. And so I can't imagine what kind of data that has. It has none. But somebody sold this to an administrator, and now they're having to throw out all this additional plastic waste for absolutely no benefit to the patient or the physician. And this is something that we hear about a lot in gynecology and really just represents some of the frustration that we can have when we're trying not to overuse things. This was an email to the AAGL listserv several years ago. And this surgeon says, we are also now being asked to change gown and gloves after any vaginal or perineal contact during a laparoscopic hysterectomy, change gloves only. If we go below for any part of the case or cuff closure on laparoscopic and abdominal cases, we can find no evidence to support such a vigorous separation of the vaginal and abdominal fields. And that's because there is none, but there's an increasing focus on changing out these supplies or redraping everything as part of infectious disease bundles that may not actually have any evidence behind them at all. So this was the award-winning paper at AAGL in 2017 from our colleagues at Cleveland Clinic, Florida. And they took patients who were undergoing TLH where the specimen would be removed through the vagina intact. And they did different cultures at all different times in the case. They did it in the vagina and the abdomen after the prep. They did the surgeon's gloves after placement of the manipulator, after removal of the specimen, and then they even cultured the laparoscopic instrument tips after vaginal cuff closure. What they found was that 99% of the cultures didn't grow out anything. And of the two that did, it was after the tissue extraction. It was on the pathology itself. So if you want to change your gloves, do it after the tissue extraction. But there's no other point in the case where it actually seems that you need to change anything at all. It's certainly not promoting patient safety. And if you even look at the cultures after the prep, the vaginal cultures had nothing at all, but the abdominal cultures were slightly positive. And I've had somebody from infectious disease look at this chart exactly and say, well, what about doing a vaginal exam? Certainly that's dirty. You know, I think the vagina is not as dirty as they think, but I think the abdomen is dirtier than we all think. And so you need to do QI projects to continually reinforce that this should be a single surgical field prep. And that's what we did at Cedars. It turns out I was trained with a single surgical field where we prepped and did everything at the same time and went back and forth without any changing of gloves. And my partner was trained to do something totally different, to do the vaginal prep, put in the manipulator, and then do the abdominal prep and cover everything with a drape so that there was complete separation of the surgical fields. We just decided to look at our data retrospectively and found, of course, there was no difference in any surgical site infection or any patient outcome after TLH. And when I was looking back for the source data, where did the separation of surgical fields come from anyway? Well, it comes from a 2011 AORN commentary who talks about how the 1994 FDA recommendation from the manufacturer on how to use their different prep kits. But outside of that, this commentary actually says there's no scientific evidence to support a prepping sequence or basically a separation of the surgical field. And as we've become more robust at doing laparoscopic surgery, we need that ability to go back and forth without having to double or triple the amount of green that we're producing in every single case. And the CDC supports this. The CDC says that surgical site infections come from the patient's own flora. And doing things like prophylactic antibiotic selection, skin prep, and metabolic control affect their infection rate way more than anything that we use in the operating room. So PPE is for you, it's personal. Use it to protect yourself. But don't think that all this extra stuff that we're adding is actually making it safer for the patient. And in regards to our surgical field, we should be looking at where we can reduce as well. We can follow the lead of some of our colleagues in hand surgery, where the hand surgeons piloted what was called a lean and green table setup, where instead of having a huge back table and a side table with large trays that were open, because these are minor procedures, decided to put it down to one table, a very small tray with just the things that they needed. Just the instruments and drapes that they needed. And they found that over 1,000 cases in one institution, they saved $13,000. They diverted 5,500 pounds of waste, and there was no difference in surgical site infections or patient satisfaction. And if they estimated that if they rolled this out nationwide, they would save $2.3 million and over 1 million pounds of waste. And I think this has really big implications in gynecology. We have the opportunity to do this for things like hysteroscopy, cystoscopy, slings. And one of my colleagues, Ali Melnick, who's at the Cleveland Clinic in the Urogyn, just presented at AUGS that she has data both on cystoscopy and placing slings and using a much reduced sterile field. And there was no difference in surgical site infections or UTIs, because what we're doing currently doesn't make sense. This is my office setup where for hysteroscopy, where absolutely nothing is sterile at all. And then the OR setup for hysteroscopy, which is exactly the same procedure, but we're creating tons and tons of waste from it. So we're going to study this as well to see if there's any difference in patient outcomes. And of course, there's probably not going to be. We also know that opening and throwing things away, it's not only wasteful, but it's also incredibly expensive. This was a study out of UCSF in their neurosurgery line. And they looked at items that were opened on the field, but didn't even touch the patient. So unnecessary opening. And they calculated that it was 13% of their total supply costs, or $2.9 million per year for one service line. 13% is more than CMS cuts adjusted for inflation. So we're really just throwing our healthcare dollars in the trash. And this is another area where we need to make sure we're doing the right thing, because many things, when they're thrown away at end of life, are triaged in an inappropriate way. So this is what I call the red bag problem. And I moved from Boston to California. I thought everything out here would be green and recycled and waste would be like perfectly minimized and triaged. And I actually found the opposite. I found that there were red bags in all of our ORs everywhere, that everything was being thrown into the red bags. Well, why is this a problem? Red bags are called regulated medical waste or biohazardous waste, and they must be steam autoclaved or incinerated at end of life. So think about everything you put into those bags is actually being aerosolized into the air. So they're not only extremely carbon intensive, but they're also very, very expensive. In California, 20 times more than the cost of regular solid waste that goes into the clear bags. And red bags actually have really specific guidelines for what should go in, but we were throwing everything in. We were throwing sterile packaging, recyclable boxes into the red bags. But red bag guidelines come from state departments of public health that were created during the HIV epidemic. So guidelines are based in fear of blood products, and therefore focus on blood. The only thing that is supposed to go into the red bags is liquid blood, saturated, wringable, dripping blood, a lap that you can wring out, not something that is stained. All other body fluids are supposed to go into the regular trash, the clear bags. And you think about it at home, people don't throw menstrual pads or diapers into biohazardous waste. It goes into residential regular waste. So again, remember that for the red bags, where the guidelines came from, what they're based in, and what they're supposed to be for. Because by minimizing their use, we can save a lot of carbon emissions and a lot of money. So I worked with our team, our environmental services, OR staff, nursing for 2 years, trying to push for this process change, because our policy actually dictated the correct triaging. We just weren't doing it. So what we did was we simply changed out our red bags for clear bags. We did the atomic habits thing, make something easy or appealing to do and make the wrong thing more difficult to do. And we put the red bag out of sight, out of mind, either out of the room or in the corner behind the anesthesia cart where it was difficult to get to. And we started this with one floor. We have 7 floors of operating rooms. We started this on the floor I operate on, so that I could really be a champion for doing this. And we measured our waste before our test of change. You can see our red bag waste was always in the double digits and sometimes was even more, we were producing even more biohazardous waste than regular waste. And after our test of change, you can see over the past year, we've had a significantly sustained reduction in our biohazardous waste into the single digits. And over 1 year, we saved $115,000. We had a 52% decrease in our red bag waste and diverted 123 tons from the atmosphere. And this was really impactful, again, because this was just one floor out of 7 floors of operating rooms. And other floors started to see this, and they wanted to do it too, because they wanted the cost savings. And because we started this little project, it then empowered other people to do their own projects around the hospital. So because anesthesia saw what we were doing, they then decided to remove their desflurane vaporizers from their carts. And that actually saved them over $100,000 per year as well, because their contract was based on the number of vaporizers that we had, and they weren't even using it all, and they were letting it expire. So all of these things saved money. The other thing that happened was we went through nitrous decentralization. With nitrous oxide is a rarely used gas in medicine in the US, but most of it is piped through hospital piping, and about 99% of it basically leaks off into the atmosphere. So that's where the impact comes from. So by shutting down those pipes and just using point of care nitrous, you can save a lot of carbon emissions. We started diverting our batteries and doing battery recycling. And then I just started not using the striker suction irrigator anymore, because I was tired of putting 8 batteries into the recycling every time I used it, and just went back to a reusable trumpet. We began recycling as well, which were in purple bags. And then we switched to reusable sharps containers as opposed to disposable sharps containers that were just going in the trash. Now a company picks it up, gives us a new one, cleans the old one, and brings it back. So lots of processes started from this interest in cost savings and waste diversion. And now we're going through our surgical packs as well and trying to reduce our surgical field. So these are our custom packs for gynecology. You can see we've got blue towels and gowns that are wrapped in soft plastic and polyethylene. That's just going right into the trash. Why are we doing that in the first place? And then why do we have all of these plastic basins when we have the metal basins in our trays that we already autoclave, and those hold hot water better anyway? These are pretty shoddy. So we empowered our scrub techs to really go through our packs and cut out everything that we weren't using, that we didn't need. And now we're looking at a trial of cloth gowns as well. That would cut down our packs even further significantly. So all of these things start to build on each other. But you might wonder, like, where does this love of single-use products come from anyway? Again, where's the source document saying that these things are better? They don't really exist. But if you look back in the mid-90s, early 2000s, there's lots of PubMed index commentaries from industry. And they say things like, well, surgeons and OR nurses prefer single-use instruments because they're sterile, safe, reliable, innovative in design, and they're always available. And so because of that, for years, we might have heard from our value analysis committee, we're not going to spend money on capital. It's easier to consign disposables and pass on the cost. We don't have to sterilize them. And disposables are better for the environment anyway, because sterilizing is so bad. But we know none of this is true. And our 30-year transition from reusable to single-use items meant that when COVID hit, we didn't dwindle away in our supplies. Our supply chain crashed immediately. And where we could have done much better if we still were focused on a reusable system. And interestingly enough, the single-use designation is not an FDA designation. This was an article that came out in JAMA just last month. The single-use designation is by the manufacturer, and it simply means that the manufacturer didn't do reusability testing. Okay, well, that's understandable. It's really expensive, but they can just create a device, slap on a label that says single use, and it's not regulated by the FDA. We really don't know how many times that device could be reused safely. There's also, this came out in one of our ACOG emails last month as well, a survey of hospital systems showing that 40% were actually using single-use equipment beyond its expiration date or reusing single-use devices because they were in short supply. So again, the safety facade, it's gone now. If COVID taught us anything, it's that these things, our supply chain's not reliable, that single use isn't better or safer for us or for patients. And even something simple like the speculum, we hear all the time, well, stainless steel speculums now, because of Joint Commission, we can't do high level sterilization. We have to autoclave them. That's bad for the environment. But another life cycle assessment comparing acrylic to stainless steel showed that you only have to use a stainless steel speculum 2 to 3 times for it to be better for the environment than a plastic speculum. You can use a metal speculum hundreds and hundreds of times, and these are in half-filled autoclave trays, so this even takes into account the sterilization process. But I don't know about you, I get emails every single week from companies telling me to switch to single-use speculums, and I'm like, guys, read the room, know who you're sending your emails to. But they're sending me these emails every single week. It's consistent, maybe the only thing consistent with my schedule. And they're saying prevent cross-contamination, a single-use illumination. Cross-contamination of what? This is a non-sterile item used in a non-sterile location. And now we're adding batteries and LED lights, which can last for more than 7 days, as I have tested in the past. And all these things are going into the trash, which is bad for us and bad for our patients. So yeah, maybe these things are more convenient to use in an ER setting or an emergency setting where you don't have access to the supplies. But in a place like a clinic where you're doing hundreds of these exams, we really should be using something reusable when it comes to safety and efficacy and what's good for the environment. You know, anesthesia has this problem too. This was a waste audit done by our anesthesiologist. Again, 1 floor, 1 week of laryngoscopes. All of these things go into the trash. And I think what this really signifies is that our guidelines from infection control really have a fear of different mucosal and epithelial surfaces that aren't skin, or that aren't our traditional like epidermis, epithelialized skin. And because of that, we don't have really good information about what's safest for patients. We don't have really good information about transmission of infection. And therefore the answer has just been, well, throw it away. Let's go to single use. That's got to be safer. There's multiple reviews, however, again, showing that our supplies, things like cloth supplies, reusable supplies, are much, much better for the environment, even when you wash them. Things like cloth gowns reduce energy consumption by 64%, greenhouse gases by 66%, and even water consumption by 83%. And how is that so? Because of the creation of the device that from its native elements and then going into the trash. Every single time, you actually reduce the water consumption when you're using a reusable. And we have continued supply chain shortages. I don't know about you, but last year I used the Rumi, but I actually trained with the Pelosi. When I got to my institution, I said, can I have the Pelosi? And they said, that's away in the closet somewhere. Why don't you use the Rumi? It's just easier. So I had been, and then one day they just said, okay, we're out of the tips. We just don't have it anymore. So this was a great time for me to ask the hospital to pull those Pelosis out of the closet. And now I use those for all of my cases. Suddenly it wasn't too burdensome to be able to pull those and put them into a tray and sterilize it for my cases. And it's the same thing with our advanced energy. One day, just the ligature went off the shelves. Sorry, we don't have it anymore. Too bad. And this is a great time for us to get used to things like reusable bipolars and reusable scissor tips. I use a reprocessed advanced energy device, but I have switched over a lot of my cases to reusable. And you might think, well, those scissor tips, you know, they're not sharp. And I have that complaint too. But that's because the manufacturers don't maintain them and don't sharpen them because they're not motivated to, because they would rather sell their single-use supplies. So this is where you can really push back on your reps and your service people and say, please maintain this reusable instrument. This is what I'm going to use from now on. We really need to work with our industry partners to reduce reliance on single use. We need to demand environmental impact label. It's like a nutrition label, so we can compare apples to apples when we're making decisions about devices. That's not just based on the single purchase price of the item. We really need to change the compensation structure of industry from sales to service. We should be buying service packages to maintain instruments, not based on commissions. This is where a lot of waste comes in, because marketing for these big companies make devices for their salespeople to sell, and that's what they do, and they do a good job of it. And then we need to make companies responsible for their own waste. It would only take one hospital system like Kaiser or maybe Mass General Brigham to say, we'll carry your device, but we're not throwing it away. You're going to have to come pick up all the waste. And I think that would change things very quickly as far as our relationship with industry. And I'll just give you an example of what a push for a single-use process can look like when it's driven by marketing, and again, this culture on theoretical patient safety without any benefit. So our ICUs recently switched over from reusable bronchoscopes to disposable bronchoscopes. You know, this has similar implications in gynecology because we have reusable and disposable hysteroscopes. So think of it similarly, except bronchoscopes are pretty advanced and they have flexible tips. And so you're throwing that away every single time you use them. So the ICU switched over to single use. There was no reason for this. It was just that sold, well, maybe it would be better for your patients. Maybe it would reduce hospital acquired infections. We don't have any evidence of that, but that's what we're selling. But the other thing that happened was that the company couldn't keep up with the supply chain. They couldn't keep the single-use ones in stock. They were going through them so quickly and throwing them away in red bags at the end, by the way. And so the company said, oh, okay, well, we can't keep up. So why don't you make sure that you have your reusable scopes on hand all the time, and make sure you sterilize them every single week so that they're ready to go just in case. So not only are we purchasing and using a single-use device and throwing it out into the red bags, we're still sterilizing reusable bronchoscopes every single week that haven't been used just in case. And this is what a single-use process that doesn't make sense and doesn't promote patient safety looks like. And there's plenty of systematic reviews to show that reusable and reprocessed instruments are no different from single-use instruments when it comes to function, ease of use, patient safety, transmission of infection, or long-term patient outcomes. And as far as reprocessed instruments, the FDA has provided guidance for those since 2000. So nobody's reprocessing things in their garage anymore. You know, this is done on an industrial level. And we need to work with our national organizations on putting out guidelines for how we can promote best practices when it comes to picking devices. The ACOG has one of the strongest statements on climate change of any medical organization there is, but they also had this committee opinion, and I've been told it's been taken down, but you can still Google and find it. And it was actually on reprocessed single-use devices, discouraging the use of reprocessed devices. They say that reprocessed devices provide no benefit to the patient or her physician. Maybe we should inform the patients that this is going on. I think this is really nuanced, and I think instead ACOG should be providing guidance for what we can do that are best practices to put us in line with that climate change statement so that we can actually do something about our own industry. This is also happening on a governmental level as well. We should be working with, well, I'll get to that in a second, but this was an executive order from Biden in 2021, where they're going to require federal facilities, including healthcare facilities like the VA and DoD healthcare facilities, to achieve net zero emissions. And they were going to start this process by removing their prohibition on reprocessed devices, and then also phasing out volatile anesthetic gases like desflurane. And this is by 2025, they're going for a 50% reduction. So hopefully that'll come down to us. It's not going to come through the Joint Commission. The Joint Commission has been questioned and challenged on their role in increasing carbon emissions from healthcare due to their push for single-use items. And when asked about it, they say, well, we're a private accreditor. We lack the authority to change regulation. And disposable versus reusable is a supply chain issue, not an issue of compliance. The Joint Commission has recently included sustainability initiatives into their hospital checklist, but those are optional to do. And I really think they're doing it because they don't want to be scrutinized for their role in pushing more waste and more carbon emissions, just like the opioid crisis. And it's possible there could be class action lawsuits against them for increasing waste, especially from local neighborhoods who are affected by increasing hospital waste. So this is something that we should really be presenting the evidence, saying, no, this is a senseless guideline. It's not in line with your sustainability initiatives now, and we don't need to follow it. The HHS put out a pledge in 2022 asking hospitals to measure their carbon emissions and then commit to trying to reduce those carbon emissions by half. And hospitals could sign on. You can see at the QR code which hospitals have signed on and which haven't. And I think this is a powerful tool to use with administrators, because if your hospital has signed on, then you can say, great, what are we doing to help reduce our carbon emissions? And if your hospital hasn't signed on, you can say, why have we not signed on? This is important for patient health. This is important for our communities. This is important for your workers as well. So I want to give you a 30-day challenge just in the last couple minutes here to think about your scopes of influence. And I want you to go to your operating room and sit there while they open your cart. And I want you to look at your tray and your cart and look at your waste bins and talk to your team about being green. And if you're the surgeon who wants every single thing open in the name of efficiency, well, that's not really efficient, and it's pretty bad for the environment. But if you're the surgeon who says, we can just have things available, we'll open it as I need, you're going to be saving a lot of waste and a lot of money for the institution as well. And also ask the institution what they're doing, ask your supplier what they're doing, what is incorporated into the things that they're giving you, what type of EDCs are there. And then talk to your colleagues about what they're doing as well and collaborate across different departments like anesthesia and other departments who use the operating room. Of course, know what's going on in local politics, but also take this as an opportunity to work with your national organizations on creating policy and creating guidelines for best practices for what we can do. And do QI projects. These are wonderful projects for residents to do, these waste audits. This was done by one of our urology residents, and he simply looked at the amount of waste that was coming out of the packs and the variable usage of each item in the packs for cystoscopy. And he estimated simply by removing the variable use items, they could reduce their plastic waste by 500 pounds per year. Again, just from cysto. So these little things add up. Every little thing makes a difference. And I know it sounds silly, but we should talk about it. And I love this quote: everybody's fighting a battle you don't know about, except for me. I am complaining loudly about my battle. Everybody knows about it. We should talk about it, because the more we talk about it, every paper, every QI project, every talk gets more attention. And we just found out this week that our AAGL delegation to the AMA actually passed policy on promoting best practices for reusable instruments and reducing waste in the operating room. So this is great news. This just happened this week. So our national institutions are getting on board. And then if you need more resources, join a nonprofit physician group. This is called Healthcare Without Harm. I'm not affiliated anyway, except as a free member. Lots of resources on there for doing your own QI projects and information to take to your administrators for starting your own projects at home. And so I'll leave you with this. The AMA Journal of Ethics in 2017 said that physicians and health organizations have obligations to use their influence, expertise, and resources to promote health, which includes promoting sustainability. And so we can change our industry. We can drive this culture. I truly believe it. And thank you so much again for having me, and look forward to any questions and discussion at this time. Thank you.
Thank you, Dr. Wright. Thank you for this excellent talk. Are there any questions?
Hi. Oh, I'm sorry.
Yes, go ahead.
This is Nancy Phillips. I'm one of the gynecologists, and I love this talk. And every time I'm in the OR, I am always appalled at the bins and the things that are thrown away and the things that are not recycled that could be. And I really hope there are people who take initiative and start committees and start implementing some of the things that you talked about in our hospital. And I wish the hospital administrators were all listening to this talk, because you put in cost, and that's what's going to get their attention. So I thank you for this talk, and I really hope it moves people to start implementing some of what you've talked about.
Oh, thank you for that. And I totally agree. When we talk to administrators, it's all costs, but this is where we really have a benefit, because doing the right thing for the climate is really good for finances as well. There's almost no instance where it actually costs more money to do the right thing for the climate. Everything that we're doing is saving money. And so it only takes a small project like the waste reduction for them to see that cost savings. And all of a sudden, we're creating an executive sustainability committee. We want to roll it out everywhere in the hospital. They want that cost savings. And so just by talking about it and getting it started, that can be really helpful. So thank you for that.
This is James Akins, one of the gynecologic oncologists. A great talk. Those of us who trained in the 80s and the 90s, we use reusable equipment, including even cloth drapes in the OR, and it worked very well. So where did the evidence come from to make the switch to single-use, equipment? Was it industry driven, or was there a hardcore, evidence that made this shift?
Yeah, great question. Even when I was a resident at Mass General, we still use cloth gowns and cloth drapes, but I remember the time when they said, "Oh, it's more convenient to switch over to single use." And I think this was the culture that was created from industry and marketing to say, you want a culture of infection control, convenience, and efficiency and cost effectiveness over everything else. It's quicker if we put everything together in a custom pack. It's quicker if we just throw it away. The truth is, it probably has not sped up our turnover times any more than using reusables did. But this was industry driven, and now the evidence is really showing that these things are not better for the environment, and they're not better for us, and they haven't resulted in improved patient safety or improved cost effectiveness or efficiency.
All right, well, Dr. Wright, Dr. Rosen has raised his hand.
Dr. Wright, I just want to thank you for your work and activism in this area. I think, like Dr. Phillips said, many of us have recognized the problem. Almost none of us have done anything about it. Like every time I'm in a C-section, I'm like, what is happening here? Even in our own unit, like I'm an MFM, and in our ultrasound unit, we had tremendously wasteful practices where we were like printing out reports and mailing them and faxing them and printing out all the pictures, even though they were being stored on the server. It took me a couple of weeks of just jumping up and down and yelling to try to get them to stop that process. Our staff that was reporting to me, ultimately, I just sat them down and read them the Lorax every day at lunch until they got sick of it. And then they finally said, okay, enough, we'll do it. I'm hoping that we can take your talk as an impetus to try to make some changes, even simple ones, at our institution. And if we have permission to share your slides, I would love to share them with our department administrators, our hospital administrators, to see at least what simple changes we can make to fix a really wasteful process. Thank you again for your talk.
Yeah, thank you for that. No, I have a full slide deck with even more hidden slides that I just don't have time to get to, and I will happily share that. And please take it to your administrators. But to your point about driving the culture with your staff, if you are that person who says, don't do this, don't open it, don't print it out, please don't open things, your team will follow, and then they'll start to see this is different, and it's in line with what they want to do. Maybe not what they were trained to do, but everybody, when they step back, recognizes what we're doing is so incredibly wasteful. And I think that's why we had a lot of success with our Red Bag project, was because people were ready and they were tired of throwing things out in such a wasteful way. So yeah, I think that's where, as individuals, we can really change the system.
I see that Dr. Bachner has raised his hand.
Hi, I just wanted to thank you for this talk. You really educated me. And I have an admin role at the hospital. And as president of the medical staff, I'm actually going to look into our sustainability. I think that there are many things we do which are wasteful. I can tell you I had, for instance, learned to do laparoscopic supracervical hysterectomies 20 years ago. And the instructor who was walking me through the process used very, very few instruments. And I was just so impressed by it. And the amount of waste that we have on any given case is just remarkable. We can generate an entire bag of waste. And it was enlightening to hear that there actually is no supportive data that what we're doing makes any difference in patient outcome or care. Um, Cost savings is obviously critical. You know, for the good work we do, we need money to do the good work we do. And if I can save $100,000 somewhere, that means patients are going to be getting something that we couldn't afford before. So I thank you for this. And I'm actually very enthusiastic about this. And I'm going to start working on this project next week. Thanks so much.
No, thank you for that. And I think we can also, as president of the medical staff or the physician group, um, we can follow the lead at McGee. They actually had a petition signed by their physicians requesting that administration take climate change seriously and take the impact of sustainability in the hospital system very seriously. And they all signed this petition and presented it to the administrators, asking them, sign on the HHS pledge. Let's start measuring what we're doing and let's start decreasing it. And they've had a lot of success in getting buy-in that way. So I think, you know, galvanizing the physicians, we're the frontline people. The administrators they don't go to the OR, they just see spreadsheets. They have no idea what it actually looks like in physicality. I actually brought them down to the operating room and made them put on bunny suits and take a look at everything we were doing. So you can galvanize the space of support from your frontline workers who are seeing this, take it to the administrators, make them aware, and then show the cost savings. It can be really powerful.
Well, I thank you, Dr. Wright. This was enlightening.
Yes, Dr. Wright, thank you so much for this inspirational talk.
Yeah, thank you. Well, I will send along the slides for everybody. And again, appreciate your attendance and engagement today. Hope you all have a good weekend and good Thanksgiving.
Thank you so much. All right, so we'll end it here. I wish everyone a safe and productive day.